Okay, good morning everybody. We can start now that we have all our speakers. I want to start by acknowledging the traditional owners of Naarm, the peoples of the Kulin Nations on whose country we gather for this event. We pay our respects to their elders past and present and to elders of all First Nations communities that are joining us here today. My name is Professor Karen Leader. I am co-lead of the Planetary Health Division at the School of Public Health and Preventive Medicine at Monash University. I co-direct a program of work called RISE, which some of you may have heard about yesterday. And relevant to this session in particular, I am leader of a health and climate initiative that was newly launched at Monash University. So it's my absolute pleasure to be moderating this session. And I thank you all who have chosen to come to this session. But third day, you know, everyone's rather tired after all the fabulous conversations, but also recognise that there is a lot going on this morning. I'm aware that those of you who have chosen to come here are probably also relatively knowledgeable about the vicious cycle that we are in related to climate change, healthcare and healthcare systems. I imagine most of you know that all aspects of health are impacted by climate change, which causes perhaps its most dramatic effects on healthcare systems, health of people, and on healthcare workers during extreme acute weather events, but which also impacts on health in many ways over the long term, changing the distribution of diseases, particularly infectious diseases, exacerbating chronic diseases such as respiratory and cardiovascular diseases, having direct impacts on many members of the community, elderly, pregnant women and others, and also having significant negative impacts on mental health. These impacts all put more pressure on the already stretched healthcare systems and the already stressed healthcare workers. At the same time, healthcare itself has a significant environmental impact, and in Australia, the healthcare sector is responsible for between 5 and 7% of carbon emissions. So in this session, we will have the benefit of hearing from 5 experts who have experience and insights to help us navigate how to move forward, how to urgently address how healthcare can become more environmentally sustainable and resilient to the impacts of climate change. We've decided to run this session with having all 5 speakers come up to the stage, and I invite you to sit in whichever order you like. And I will introduce each of the 5 speakers up front, and we'll be asking each of the 5 speakers to address a specific question. And if I could ask the audience to please think of questions during the session, and at the end of the 5 presentations, we hopefully will have significant time for discussions and for your questions to be answered. So the first speaker, who is my pleasure to introduce, is Dr. Madeleine Skellen, who is the Director of the National Health and Sustainability and Climate Unit in the Australian Government Department of Health and Aged Care. Welcome, Maddie. The second speaker is Paul Clarinar, who is Director of Population and Planetary Health in the Northern Sydney Local Health District of the New South Wales Government. Our third speaker will be Professor Katie Bell, Chief Investigator of Wiser Healthcare and an NHMRC Senior Research Fellow in the School of Public Health at the University of Sydney. The fourth speaker is Professor Nick Watts, who is currently the Director of the Centre for Sustainable Medicine at the National University of Singapore and is also the former founding Chief Sustainability Officer of the NHS in the UK. And finally, we will hear from Associate Professor Angie Bone, who is from the Monash Sustainable Development Institute and the former Deputy Chief Health Officer of the Environment, Chief Health Officer for Environment in Victoria. So Maddie, if I could start with you and ask you the question, how can government set the enabling environment to advance sustainable and resilient healthcare in Australia? And I invite you to come up here.
Well, thank you very much for the invitation to speak. It's great to be with you. So it's been a real honour over the last year and a bit to lead the work to develop and now implement Australia's first National Health and Climate Strategy. And I just wanted to acknowledge the amazing contributions of our incredible network of stakeholders that worked over many years, firstly to advocate about the need for development of a national health and climate strategy, and secondly, that made the contributions that many of those stakeholders, including many of you here in the room, made to development to the development of the national health and climate strategy over the last year. So thank you all. I also wanted to thank the organisers for asking a specific question here to ask about what we can do to create an enabling environment for action, because I've got a standard stump speech about the strategy I've given many times over the last few months, and this question forced us to think a little bit differently, and it's a good challenge to be posed. So what is the strategy? So the strategy is a whole of government plan for addressing the health and wellbeing impacts of climate change, whilst also addressing the contribution of the health system to climate change through the generation of greenhouse gas emissions in care delivery. So there's 49 actions in the strategy that we're committed to delivering over a period of 5 years. We aim to deliver them in less than 5 years, but those actions, many of them we will be leading as the National Health Sustainability and Climate Unit, but there's also actions that will be led by other parts of government, actions that will be co-developed with state and territory health departments, and also co-developed with other partners in the community. So just a brief bit about the strategy before we dive into answering the question. So the vision statement for the strategy is healthy, climate resilient communities and a sustainable, resilient, high-quality net zero health system. And we develop actions or commitments around 4 objectives. The first is health system resilience, and that means 2 key things. Firstly, it means building the resilience of the health system itself to the impacts of climate change so that we can continue to provide high-quality care in a changing climate. But perhaps more importantly, it also means taking actions within the health system to build population resilience to the health impacts of climate change. Secondly, health system decarbonisation, that is building a sustainable, high-quality, net zero health system. And I just wanted to dwell on the high-quality bit there, because we're very much of the view that many of the changes that will be needed to decarbonise care delivery will require us to look at the models of care that through which care is being delivered, rethink them, and they will also open up significant opportunities for improving care quality and outcomes. Thirdly, international collaboration. So, climate change is a global problem, and so we recognise that the response to it needs to also be global. And so a significant part of our work is collaborating internationally, firstly to strengthen our efforts to build a sustainable and climate resilient health system here in Australia, but secondly to support efforts to build sustainable and climate resilient health systems in our region. And finally, health in all policies. What we mean by this is that action to address the health impacts of climate change need to go beyond the health system. So firstly, adaptation actions to address the health impacts of climate change need to encompass action in health determining sectors, thinking about changes to the built environment, to housing, to travel and transport, to diets, nutrition and agriculture, to urban planning. And so a lot of our work involves collaboration across the Australian government to achieve those things. And also, we think on health in all policies, there's an important role for the health sector to promote and highlight the health benefits of emissions reductions across society. Okay, so the strategy does have some enablers in it. This is not the main thing I wanted to talk to you about, but I just did want to mention them because they're called enablers. They have a particular meaning in our strategy. They're the actions that will be required across all 4 of those objectives. So just to briefly run through them. Firstly, workforce mobilisation, building awareness of climate and health into fundamental training curricula, continuing CPD, thinking about developing leaders, champion programs like the Net Zero Leads in New South Wales Health, also supporting the health workforce in relation to health and wellbeing, as they're often the frontline responders in relation to climate-related emergencies and extreme events. Secondly, research and innovation. We know that there's massive evidence gaps in relation to the impacts of climate on health, and also in relation to what we can do to address those impacts and build a sustainable health system. So we think there's a role for us to play in identifying those research gaps, but also identifying where there are sources of funding to support additional research to fill those gaps. Communication and engagement, we've got a range of kind of patient-facing and clinician-facing education materials planned, and collaboration and governance, just recognising that we can't do this on our own. We need to work with others, and we need to have the governance structures in place to facilitate that collaboration. Okay, so on to answering the question. We kind of tried to have a think about what we can do to enable action, and we came up with a taxonomy. I fear it may be quite feeble, and I just wanted to put a challenge to the audience to help us to improve our taxonomy. It's basically 3 things: convening and supporting. So that is lending support, bringing stakeholders together, or lending support to initiatives by others to bring stakeholders together to plan collective action. Secondly, providing advice and guidance, providing thought leadership, providing information about best practice so that it can be disseminated. And thirdly, what we call policy and regulation, and I'll have more to say about that and why I think that you really can be thought of as an enabler of local action. Okay, so on the convening, we think there's amazing things happening in different jurisdictions, in local health systems, and we think there's a role for us to play in joining that up. And an example of that is that we're bringing together stakeholders across health professional groups and different jurisdictions in Australia to develop a plan to phase out desflurane, which is an anaesthetic gas which is a source of significant greenhouse gas emissions in the health system. And we need to develop a plan to phase out its use from the public hospital system. That's happened in a number of jurisdictions. We're bringing together people to figure out a plan to finish the job. But convening also involves maybe not us leading the convening, but supporting initiatives by others. And I just wanted to mention a couple of such initiatives. Firstly, Asthma Australia has established an incredible collaboration to simultaneously improve respiratory health outcomes while reducing emissions from respiratory inhalers, which is another significant source of greenhouse gas emissions. That brings together patient groups, clinical groups, academic leaders, and also many governments. Through actively supporting that, rather than trying to do our own thing separately, I think we've accelerated those efforts and, accelerated change. Another initiative not on my slide is that we were delighted to participate in a first workshop on Monday of a consortium led by the Monash Sustainable Development Institute to bring together health sector leaders from different jurisdictions and health services across the country to develop a plan to achieve a net zero health system. Again, we're not leading that, but we're supporting those local efforts. There's also, I think, an important role for us convening in providing a link to international action. So that is participating in international actions and connecting them to local and jurisdictional initiatives. And in that respect, I'm delighted to be able to, tell you about an initiative that we just joined yesterday. The Australian government has joined an international collaboration led by the United States and NHS England to decarbonise healthcare supply chains, and we're hoping to connect that to our local efforts with jurisdictions. There's another effort here to develop new international standards for measuring the environmental impacts of health technology products, which we've been working on with Katie here, who's on the panel, and she's going to have more to say about that. Okay, advice and guidance. So this is a pretty standard one. It's just about providing information about best practice so that that best practice can be disseminated. And I just wanted to name a few initiatives in this respect. Secondly, another big anaesthetic gas that is a big source of emissions is nitrous oxide. And we have an action to significantly reduce nitrous oxide greenhouse gas emissions. It turns out that more than 70% of those emissions come from leaks in hospital piping systems. And so we're delighted to have recently partnered with some academics at University of Melbourne to develop guidance on how to identify and reduce those leaks, and hoping to be publishing that later in the year. Secondly, guidance on how to conduct climate risk assessment and adaptation plans for local health systems and health service providers. Thirdly, connecting to those international efforts on supply chain decarbonisation, we have a plan to co-develop with a number of different jurisdictions guidelines on green procurement and sustainable resource use. Final slide, I hope I'm going okay for time. Policy and regulation. So we were kind of debating whether or not to include this slide, because there's a point of view which says that enabling is about supporting bottom-up action, whereas if you regulate, that's about imposing change from above. But I wanted to problematise that distinction by an anecdote, which is that in the process of developing the National Health and Climate Strategy last year, an incredible number of stakeholders, both from health service organisations, state and territory health departments, when we were talking about a topic, might be procurement policy, might be climate risk assessment, they would say to me, "You should make this mandatory." At first I think I missed a trick in understanding what they were really saying, because I was reporting back to my leaders, "Hey, look, we're pushing in an open door here. Everyone supports us, like just mandating this and getting on with the job." What I later realised was that what people are really saying when they say that to me is, "I'm having trouble landing, I want this to happen. I'm having trouble landing this with my organisation's leaders, and if you mandate it as the Commonwealth Government, that will help me to do my job." So in that sense, I do think that regulatory action can be thought of as having a place to support local champions, support people who want to drive change, to do the things that need to be done, creating that enabling environment within those organisations. So we, as the Department of the Health and Aged Care, and we operate within the Interim Centre for Disease Control within the Department of Health and Aged Care. We don't have any direct regulatory functions related to climate and health, but the strategy does include a range of actions involving us engaging with other bodies that do have regulatory functions to incorporate climate and health considerations into their work. So one is incorporating net zero building standards and climate resilience considerations into the National Construction Code. And another, which is I think one of the most exciting pieces of work happening in this space, is that we're supporting work being led by the Australian Commission on Safety and Quality in Healthcare. And I just wanted to acknowledge that we've got the CEO of the Commission here in the room, Anne Duggan, doing amazing work to pilot safety and quality standards related to healthcare provider sustainability and climate resilience, thinking about what role they might have in future revisions to the safety and quality standards. So, that's amazing work, and it's by making use of those levers to support local action that I think that the Australian government as a whole can facilitate change at the local level. Hopefully that responded to the question, but I also do really want to emphasise I'd really welcome comments from the floor to improve our taxonomy and say what might be missing in terms of that list of enablers of action. Thank you very much.
It is on. No wonder I couldn't work out how to switch it on. That was fabulous, and actually really gives me new hope in how we can tackle this with the government support. And I think your explanation of why how you see your role as enabling is a really fabulous insight. So thanks for that. Now, Paul, I've had the pleasure of meeting you a couple of times over Zoom this year because I had heard of the incredible work that the Northern Sydney Local Health Division is doing. And from my humble perspective, but I really think this work is a world exemplar of driving net zero through health service leadership. And I wonder if you could describe for the audience here what you're doing, but also importantly what the challenges you see are and what opportunities there may be for the next steps.
Well, thank you, Karen, that's very kind. Well, basically in Northern Sydney LHD we took a comprehensive carbon footprint of our entire system We identified where the hotspots were, and then we came up with a plan to do something about it. So 3 simple steps, but probably 4 years of toil and a lot of complexity involved. And so I might just take you through some of the things we found, and then some of the challenges and things that we're moving towards. But just to caveat that I'm jumping around in time. It's a bit like Pulp Fiction. I might start at the end, go to the middle, go to the start, and then back to the end. So the slides go forward like that. So this is, I suppose, what we're at the moment. We've just launched our new planetary health framework, and that came from a lot of consultation evaluating the previous framework, which was pretty rudimentary, and then coming up with a systematic way or a pathway to get to our net zero target, which I'll mention in a second. In the first instance, we were funded by Treasury and engaged the consultant Arup to do what we believe is the largest or most comprehensive footprint of a health system in Australia so far. And that slide gives you a bit of a nutshell on what we found. And scopes 1 and 2 are the things that we can control. It's basically the fuel and the electricity we use to go about our business. And then scope 3 is the things that we don't control directly, but we can or we hope to influence. And it's largely to do with the external providers and consultants and so on that we deal with, and the footprint that they leave behind. So moving on to the hotspots, and yeah, not surprisingly, the electricity we use to go about our clinical practice mostly, but then all the other types of work we do as well, left the biggest footprint. And then the second one is the footprint that our suppliers and our commissioned services are producing. And the third thing, interestingly, is staff commute. So the way staff are getting to and from work left about a 9.7%, something like that, footprint. And there's these slides. Well, in fact, our planetary health framework is available on the Northern Sydney Local Health District website, if you're interested, and that sort of has a bit of this breakdown involved in it as well. Otherwise, you can email me, paul.clarinar@newsouthwales.health, etc. We came up with a net zero target based on what we found, and using the UN Science-Based Target Initiative to guide when we thought we were going to get to net zero. So we've got the standard way to get to or to measure net zero is scopes 1 and 2, in terms of how the government and other agencies worldwide are sort of coming up with that net zero target. But scope 3 is obviously a huge contributor to our footprint, so we needed to include a plus target there. So effectively, we've got net zero by 2035, but our plus target, which is all scopes, by 2050. In terms of developing a pathway and working out what we need to do to reduce our emissions, there are a range of interventions across the system, really, that we need to consider. But because we are a health service, models of care sort of gets the star billing and gets the attention, and so it should, because that's the point of difference where we can make a difference to our carbon footprint. And so obviously primary prevention and reducing low value care is at the top of the list. And then other examples include the medical gases, the reduction of desflurane, that high carbon intensive anaesthetic gas, and nitrous oxide, etc. Energy efficiency is a big part of any organisation, really, in terms of how they can reduce their footprint. And that involves the way they use and the type of electricity they use. The greening of the grid as a sort of an overarching change, a macro change that's happening, will help us get there in terms of energy efficiency. And also tuning buildings and things like that, having air conditioners that don't run all night and leaving lights on and things like that. And upgrading LED lighting and all of those things that you're aware of. But we're a big system. We're 7% of the footprint overall in Australian society, so we can make a big difference by working on things like energy efficiency. Electrification is again taking advantage of that greening of the grid, and then supply chain is that big chunk of the scope 3, which is our suppliers and contractors. What our scope 3 is their scopes 1 and 2, and we need to work on our contracts and our ways that we deal with them to encourage and sort of push them to be more sustainable and have their own plans. Sustainable travel is, from a population health point of view, a really good thing, and from a planetary health perspective, it's the same. And we need to work out ways to design our cities and to work with local government and planners and so on to make it easier for people to get around without using cars, and otherwise take advantage of remote working and working from home and that type of option as well. Waste is I think it's what comes to people's mind when they think about helping the environment and doing what can they do about it. And so probably 95% of the suggestions and or complaints that we get from consumers and staff are around recycling and reusable plastics and things like that. And so that's a big part of our plan. And then medical gases, like I mentioned. So the framework is divided now into 6 main domains, and I'll go through those in a sec. The very outside there are the enablers, which we've sort of focused on to help us implement the actions within those domains. And they include research and measurement. Leadership and governance is really important, and accountability, how we report what we're doing and how we communicate that. And then Indigenous and cultural science is a real... There's such a huge synergy between planetary health and Aboriginal and Torres Strait Islander health, and the way the stewardship that our First Nations people have had for this land for so long, the appreciation of what we take, we must give back, we must thank the earth for the way we're using it and not abuse that. And so that language and those concepts are infused in this framework really throughout the framework, and we try to sort of bring that net zero carbon accounting sort of very analytical and sort of quantitative language, and try and express that in the Aboriginal kind of principles and theories and language as well. And so with the domains there, governance, in fact, I'll go ahead and then back, but governance is, I suppose, where it all started in terms of our CE at the time, about 4 or 5 years ago, sort of, we were having a meeting about population health, and she'd just been to a workshop run by Tony Capon, and was really interested and enthusiastic about planetary health, as well as obviously it was on the radar already, and it's more and more on the radar every moment we go along, really. But the idea was that we need to do something about that. We need to take some kind of leadership, and we need to have a plan. And so the first thing was to set up a bit of a structure. So this is, we've done it this way. Obviously there's different ways to do it, but you really need to think hard about how having a sort of a legitimate, formalised structure that has reporting lines, has people accountable, and so on and so forth. And people who can advocate for more workforce and more capacity to achieve these things. And, the capacity with all our economic and financial sort of pressures at the moment with healthcare systems, planetary health and sustainability is recognised as something that's a priority, and it's something that being the director of this division I've benefited from, because I've been able to actually create some positions and have some people dedicate their 100% of their time towards this. And then you're not asking people who've been working in corporate services or finance or environmental services or in allied health or wherever they might be within the system, they all need to be working towards planetary health. We're not just asking them to do this on top of what they've already done. There's definitely that perception, and that's one of the really big struggles and efforts is to bring people along, and not only just by sort of impressing on them how important this is, and it's, we've all got to do this for the planet, but it's not that hard, and it is part of your job, and that's much easier when you've got people dedicated to the space, and then they can provide a lot more assistance to regular workers who are doing that work. So so that's I won't go through the chart there, but along the bottom there are our local committees, and again there's some sort of tension, if you like, where we do want to encourage local committees and they're the ones with the really enthusiastic sort of advocates and activists wanting to do as much as they can in that space, and encouraging their ideas and potential interventions and so on, but then bringing it into an overall sort of framework, which is what we have now through the Central Planetary Health Committee, out through the strategic plan and to the board, so that everything that happens in the context of our overall plan, and there's less likelihood of duplication and things like that. So just going back to the other domains, energy and assets is pretty straightforward. Waste management and resource recovery, people and places, models of care. People and places is around placemaking, it's around planetary, it's around social well-being, it's around engaging with nature, it's around bringing people along on the journey, and that's, I think, a real key part of, and somewhere where the health system is really well placed, because generally we've got a lot of people working for the right reasons and who are wanting to do this sort of work because it's the right thing to do and they're enthusiastic about it. So we've got a willing audience there, and we need to sort of take advantage of that. How am I going for time? A minute and 2 minutes, that's good. Okay. And then I'll just flick through to, this is the sort of the dashboard that we have at the moment in terms of reporting and evaluation in a sort of in a ready to see view, but that's going to be a body of work happening this year and then into next year, so that we've got really easy to engage with sort of metrics and ways to sort of track our progress. But again, the pie charts at the bottom there are a slightly different way to describe the carbon footprint information I provided earlier. And then the next step, so it's to continue with our solar projects, to roll out and expand our fleet of electric vehicles to align with the government target of being 100% EVs by 2030. The Ryde Hospital redevelopment will be the first fully electrified, is that the word? Electric hospital, and taking advantage of the greening of the grid. And then the people and places, that bottom picture is a picture of Nature Fix in action, and that's a digital wellness platform about encouraging moments with nature, with visitors, patients and staff themselves. And then, of course, we've got active and sustainable travel that we need to work on. And I suppose one thing for the future we're very keen to work on is to quantify the benefits of primary prevention and social determinants in terms of its carbon savings. And so it's the same thing with primary prevention and social determinants, in that it is hard, even in terms of hospitalisations prevented, it's a difficult thing to quantify, but we have the sort of dynamic simulation modelling capacity to do it. It's just a body of work that needs to be done. And then that justifies that work, which is, we all know, really important even further. And and the last picture is the woman on the top left holding the big globe there is Nicola Grosskops, and I just want to shout out to her and thank her very much for leading this project. She's the manager of planetary health within Northern Sydney Local Health District and put these slides together for me, in fact. So I'm very grateful. And thank you very much.
Great. Thanks so much, Paul. And I think one of the things that stands out to me is the fact that to do this properly and to do this well does take some resources, but that if you can quantify the benefits, then you can perhaps be towards convincing those who in our healthcare systems do dictate the purse strings that it is worthwhile. So I really am inspired by that. Okay, Katie. I wonder if you could tell us about the work you've been doing with WHISER on driving towards net zero through HTA, and also give us an idea of other efforts that can support health services to get to net zero through limiting low value care and moving to low carbon options for necessary care.
Thanks very much for the opportunity to be part of this really interesting panel and conversation. So I've got a bit of a focus on using HTA as a means to low carbon care, but we'll touch on the other aspects in the question posed. First, I'd like to acknowledge Aboriginal and Torres Strait Islander peoples as the first custodians of the lands, seas and waterways of Australia, and I respect and honour elders past, present and future, their culture and knowledges that have intrinsically cared for country for over 60,000 years. And in this spirit, we commit to building a sustainable future together. So I'm presenting on behalf of a large research collaboration called WHISER Healthcare. There's some other members in the audience. So this is a collaboration of over 130 researchers across 4 institutions, and that's the chief investigators pictured there. And I should say that WHISER Healthcare aims to really promote better value care by particularly limiting low value care and in particular overdiagnosis and overtreatment. As an extension of that core mission for WHISER Healthcare, there's a group that we're calling WHISER Carbon Neutral, which is promoting not only high value care, but high value low carbon care. And there's some key players pictured on the slide. So just to set the scene for how WHISER has decided to go about trying to help systems get to net zero. So as we've heard, not only does the climate impact on health, but health systems are actually polluting and part of the problem. And in Australia, the carbon emissions are actually almost half that of the construction industry and continue to grow year on year. Some work that Alex Barrett led, looking at a detailed report of the NHS that I think Nick Watts was a co-author on, was quite revealing in that it actually shows that although 40% of the emissions are probably due to those scope 1 and 2 emissions that you have direct control over, and that things that Paul was mentioning about trying to move to renewable energies and solar panels on hospital rooftops and electric vehicles are all very important for trying to reduce that 40%. There's still that large 60%, which is actually quite similar to the findings you just presented for North Sydney, that scope 3, and a lot of that is actually clinical care. So if health systems are to reach net zero, it's not going to be enough to do all the renewables and the improved buildings. We really do need to target clinical care itself. And in this analysis of the carbon footprint of that clinical care, we are able to see that there's actually a large carbon footprint from outright harmful care, low value care, and then also a carbon footprint from the high value care. And different approaches will be needed to reduce the carbon footprint from these different types of care. So just on to our efforts to try and get this on the agenda for HTA. And there's been a really nice collaboration with Madeline and her team that has resulted in getting this into the options paper that was released as part of the HTA review that's happening in Australia. And so there's a section in that policy paper saying that one of the options that HTA needs to consider is the environmental impacts on HTA. And specifically, the option suggested is that we could require the actual applicants for listing on things like the MBS and PBS who are wanting government subsidy of their products. So these are the pharmaceuticals, the tests, the different devices, to actually report what the carbon footprint is of their products. In a similar way to currently, they're required to report the clinical effectiveness and the cost effectiveness. So we're proposing that we could require the applicants to report not only those carbon emissions of their product, but also the comparator, and that this could be a really powerful way to get carbon footprint information on lots of individual healthcare, which at the moment is mostly unknown. So we propose that this would be beneficial for both the policymakers, so the people deciding whether to purchase the healthcare products or to reimburse, so it would help them purchase the low carbon, clinically effective and cost effective healthcare. But it would also be really beneficial just to get that information out there so that clinicians and patients who are actually wanting to choose the low carbon care will know which care they can choose. So just talking briefly about how the carbon information could help HTA decision makers choose low carbon care. So this is a table put together by my colleague, Professor Rachel Morton, just to illustrate how these decisions can be modified by carbon footprint information. So at the moment, committees such as MSAC and PBAC use metrics called incremental cost effectiveness ratios, which basically are considering outcomes in terms of clinical effectiveness and cost effectiveness, and pretty much come up with the end result that a new product compared to the comparator is either more cost effective, the same, or less cost effective, and that is used to decide whether or not to reimburse the new technology. So if you add carbon footprint information, you can see that this could actually be used to modify some of those decisions that are based just on clinical effectiveness and cost effectiveness. So in particular, if you look in the middle column, which is perhaps the same or similar cost effectiveness, but the new technology has a higher carbon footprint, then that could be used as a rationale to not choose to reimburse that product. Similarly, in the bottom row, if the new product was shown to have a lower carbon footprint, then that could be used as a rationale to actually decide that would be worth reimbursing. And just to answer something that Madeline foreshadowed in her talk, there is concern about this, that we do need robust standards for the carbon footprinting, because there is a real potential that companies could just greenwash their product and say that their product is lower carbon footprint. So we need to have robust and reliable standards to be sure that their carbon footprints are accurate. And there's an international methodological group that are working on this at the moment. Just the last slide on the HTA decision makers piece. So we've just recently published a scoping review where our PhD student looked at what methods have been published in terms of how you could include carbon emissions in a health economic evaluation. And So there's various ways that people have described, but nobody's really tested any of these for how feasible or acceptable they are to committees like PBAC and MSAC. So now just briefly to talk more about how the carbon information can actually help clinicians and patients to choose low carbon care. And so back to Alex Barrett's diagram of the different types of carbon footprint for different types of care. So if we group the harmful and low value care together, this is care that we don't really want to do. And so there's already reasons to not do it from a health point of view, a financial costs point of view, opportunity costs to clinician time and patient time. But carbon footprint could be an additional lever to help clinicians and patients resist doing low value care. And so just a couple of examples of active areas we're working in at the moment for this. ICU has been found to be both a low value care hotspot and a carbon hotspot. And so there's efforts underway to try to reduce routine testing, both blood testing and chest x-rays in the ICU as a way to lower carbon footprint. And another new area that we're involved in trying to work towards is the low-value surgery procedures that the ACI and New South Wales Health have identified as potentially often low value. So exploring whether providing information about the carbon footprint of these procedures might be an extra motivator to not undertake them. And lastly, I'll just talk briefly about the high value effective care and the need to move that to low carbon models. And so there's mentioned the need in anaesthesia in particular to move to not use gases like desflurane and also there's the potential to move away from any volatile gas to total intravenous anaesthesia. I think Paul was mentioning virtual care as well. And then the other one that Madeline had mentioned about respiratory inhalers seems to be a really clear example where that carbon footprint information could be really useful to patients and clinicians to choose low carbon options. So this table here shows the massively lower carbon footprint of a dry powder inhaler like Bricanol compared to the metered dose inhaler like Ventolin. But in this country, and in fact most countries, by far the majority of the reliever inhalers that are used are the Ventolin inhalers. And so that was just a very quick overview of some of the work that Wiser Healthcare is doing, but please do get in contact if you'd like to find more or collaborate. Thanks very much.
Katie, I really do commend you and the teams you're working with on the practical work that you're doing and how you're really showing where the hotspots are that we should be concentrating on. So thank you for that. Nick, you've got experience implementing net zero in the NHS in the UK and now we're doing this in Singapore. So I wonder if you can briefly describe the situation in each location and where you're finding there's transferability of what you did in the UK to what's happening in Singapore and what we can learn from this in terms of transferability elsewhere towards driving towards net zero climate resilience to other healthcare systems.
Sure. Hello, thank you. Thanks for having me. I'll be as brief as I can because I think we've got some questions and that'd be more fun than whatever nonsense I've got to say. The UK and Singapore are very, very different countries. Surprise, surprise, it's hotter in Singapore. I think if you go and take a look at sort of mostly upper middle income country, high income country baselines, and you can do this and people have done this, it's simple to get a snapshot of where the emissions profile of a healthcare system is. Takes like half a week, really, and someone with some sort of basic familiarity in some of the software packages that run this stuff. Pretty much all the healthcare systems look pretty much the same, right? All the baselines. You go and see the pie charts up there. All the pie charts we've shown there, they looked pretty damn similar to me. They look pretty damn similar to all of the hospitals I've seen in Singapore. They look pretty damn similar to the stuff we did for the country of Singapore, and they look incredibly similar to the 212 trusts of the NHS and the 40, God knows how many integrated care systems in the entire country's healthcare system as a whole. So it turns out that our healthcare systems are actually pretty similar. And so the emissions profiles of our healthcare systems are pretty similar, and the supply chains of our healthcare systems are pretty similar. We reckon in the NHS we share about 85% of our supply chain with the United States. We reckon we share about 92% of our supply chain with the healthcare systems of Western and Central Europe. And so, it's sort of no surprise that out the other side of that, things look pretty much the same. And so as a result of that, the categories of interventions that you want to run at are pretty much the same as well. If you show up at a talk like this in London, someone will say the word desflurane and everyone will go, yeah, I get it, I've heard that before, thanks. And someone will say the words metered dose inhalers and you'll go, yep, yeah, thank you. And someone will say nitrous, and then someone will say building standards, and someone will say procurement, criteria, et cetera. So those categories of interventions are basically the same, because basically the baseline of the healthcare system we're talking about is the same. But I think that might be about where that ends. And I think what I've found in Singapore compared to the United Kingdom is that, God, the culture of the country is different. They're both very, very high-income countries. Singapore is about 1.7 times higher income per capita than the United Kingdom. The United Kingdom is very, very capital constrained, so when you talk about the need for energy efficiency measures and on-site renewable generation and electrified fleets, the United Kingdom goes, oh God, £7 billion looks like quite a lot of money. And Singapore goes, oh, is that all? Cool. The engineering solutions out the other side, though both of them share about 12 to 14% of their emissions profile in on-site fixed asset sort of emissions, in the literal emissions from the building and the concrete and the energy. It's obviously pretty different when you sort of peel back behind that, because in Singapore they're spending most of their time cooling buildings, and the United Kingdom they're spending most of their time heating buildings, and they're doing it with two very different sets of technology, and the solutions available to them to be able to respond to that are very, very different, because where the hell are you going to put all the solar panels in Singapore? There's no space. To be honest, where the hell are you going to put all the solar panels in northern England as well? There's no sun. You end up sort of looking through all of those things. You end up saying, well, okay, fine, Singapore is quite a digitally enabled healthcare system, so the emissions from cars, from patient travel, staff travel, visitor travel, still there, still 8-9%, not as high as you might expect in Australia. That makes kind of perfect sense. There's bigger concepts of rurality in Australia than there are in the United Kingdom. I'm not sure Singapore has a concept of rurality. Malaysia, maybe. But because it's digitally enabled, because it's denser, slightly less of a challenge, but you do still have to electrify that fleet, right? It'll result in slightly sort of smaller savings than it might otherwise. You find that sort of the supply chains, while they look similar on the face of it, turns out, on the one hand, the NHS is bigger, much bigger, right? 2.2%, 2.6%, depending on who you ask, of the global pharmaceutical market. That's actually quite large. There aren't that many single purchasers that are that big, the United States, but it doesn't really act as a single purchaser. Singapore, much, much, much smaller. But interestingly, it controls the regulatory environment for the Asia Pacific. Not so much Australia, but almost every single medical device company and brand pharmaceutical company in the entire world has its APAC headquarters in Singapore. And as a result of that, it projects those regulations out to ASEAN and to a lesser extent out to the rest of the region. And so it actually has quite a lot of regulatory power and has had a lot more success than the United Kingdom has had in managing the reprocessing of medical devices. It kind of does that stuff naturally. All of this is to say, I think we have a lot of commonality in the actual core of the problem, in the baseline of our stuff, and hence a lot of commonality in the categories of the interventions. because we have slightly different path dependencies of how the healthcare systems came together, because they live in slightly different regions, because the geopolitics of that region is slightly different, the culture of the country is slightly different, the demography, geography, etc., is all slightly different. The actual way you run at this, if you are Maddie trying to set up a national program to run at this, or if you're Paul doing it in a local health district, is completely different. There where I see the similarities, I think, and to talk a little bit about how the NHS sort of breaks this stuff down, we don't think of this as a technological challenge, and we don't think of this as a financial challenge. We think of this entirely as a change management problem. We think of this as a mobilization challenge. We actually think most of the technology we need is pretty readily available, and we think most of the capital is actually pretty readily available as well. Permission matters. So you have to shout regularly, and you have to shout loudly, and you have to make sure that everyone, if you're the NHS or 1.4 million of your healthcare professionals, that they hear that the NHS expects that a high-quality healthcare system and a high-quality clinician runs at this. You do it in a bunch of different ways. You can have a national strategy, you can launch it at COP, you can embed it into the beating heart of the NHS and the Health and Care Act of 2022, or you can put it into your regulatory framework in Singapore of what it means to be a hospital in the public system in Singapore. Contracts work, communications works, legislation works, but permission's important. Capability and capacity are important, so you have to fund some of this stuff. It doesn't cost anywhere near as much as someone that's complaining about how difficult the world is will tell you, but you do have to fund it, and you do have to make sure that you invest in getting people up to speed on this stuff. Unfortunately, there are not a huge number of particularly excellent sort of training courses out there, and that's kind of because when you say, what do I need to do to respond to climate change in a healthcare system, there isn't 6 or 7 things like there is in the power generation sector or in the transport sector. There's like 20,000 things, because medicine is weird and diverse and like kind of all over the place, and each one of those different specialties and localities have their own weird suite of interventions. And so I think for the most part, if you are going to bring people up to speed, if you're going to create some of that capability, you have to give people the space to try some of that stuff out and mess it up repeatedly, and then slowly sort of come along. And that brings me to the final thing that I think is important. Permission matters, capability and capacity matters, and finally, fun matters. This stuff is hard, and it's going to take 25 years, and we're going to miss a lot of targets. And unless we do a better job of supporting each other, unless we do a better job of kind of not being the like environmental fun police. No one likes the guy that like runs around saying, don't recycle in the yellow bin, recycle in the purple bin, or in the like tiger colored bin, or the whatever. Unless we do a better job of letting people kind of go nuts and follow their passion and, you know, care a little bit less, frankly, about precisely whether or not it is the single most important, single highest carbon thing we could tackle, and care more about whether or not someone is taking action and learning something and having fun at 9 a.m. tomorrow morning. Unless we do that better, Anzac Day tomorrow morning, so maybe not 9 a.m. tomorrow morning, Friday. Unless we do that stuff a little bit better, like I think we're going to run into a lot of trouble. So I think that answered the question. Lots and lots of differences, but I think the commonality in the like change management approach that we run at this stuff, there's a change management literature out there that I think runs along some of the nonsense I was saying, accountability and permission, capability, capacity, and I think they call it interconnectedness, but that's a big word and I prefer fun. Thank you.
Thank you so much, Nick. That was fabulous. And no space or rurality in Singapore, no sun in the UK, right? Now, Angie, I have an apology to make to you, Angie, because Angie and I actually put this program together, and Angie said to me, I think Nick should be the last speaker on the panel because he's a hard act to follow. And what I have done is put Angie as the last speaker on the program. So I'm sorry, Angie. But I think that it does... the question that I've got for you is, I think, where we do want to finish. And it's clear we need to make change if we want to make our healthcare more sustainable and resilient. How do you think we can actually make this change happen?
Okay, well, thanks Thanks, Karen, and thanks to the rest of the panellists, and thanks to everybody here who's chosen to come to this session rather than some of the other sessions. I hope what I'm going to do is talk about some of that change management that Nick was talking about, and I'll try and make it as fun as possible because I do agree. So I've spent 20 plus years working in government trying to make change happen. And I'm a public health physician by training, and those public health skills have got me some part of the way, and some change has happened. But as we get closer to 2030, closer to the kind of climate crisis that we know that's coming, I've got much more interested in how actually does change happen, how do we make it fast, and how do we put our efforts where we're going to have biggest impact, because we've got no time to waste. So, having moved from government, I'm now so grateful to be working at Monash Sustainable Development Institute, which is an institute of Monash which is totally devoted to advancing the well-being of people and the planet for current and future generations. And it's a genuinely transdisciplinary institute working across faculties, across sectors. And I'm learning so much from other sectors as well to help us with this challenge in health. So, I'll just work out how to use the gadgets. Oh, it would be me, wouldn't it? What do I need to press? The green button? I'm pressing an arrow that should take me forward, not back. I'll try a mouse.
Yeah, now try the arrow again.
Okay, let's try that again. Oh, yay! Excellent. Sorry about that. So this is MSDI's kind of philosophy of how change happens. It basically recognises that we need change at all levels. This isn't just about the top-down government or the bottom-up healthcare workers. This is action that's needed at macro, meso and micro level. And you can come into this virtuous circle that we can create at any point. And the idea essentially is that if enough individuals change their behaviour, the way they're acting, what they're calling for, we can shift systems, policy and institutional systems. And as they change and they become more enabling, we can then change more behaviour. So that's the idea behind everything that we do. So starting off at the macro side of things, some of you may be aware of Donella Meadows. She's one of the kind of goddesses of systems thinking, of system dynamics. And if you have time to read her article, which is there linked at the bottom, I'd really, really recommend it. It's very accessible. She tells the story about how we're all looking for silver bullets, and we all actually instinctively know where the levers are in systems to change things. But if we don't think carefully about this, we usually pull the levers in the wrong direction. So she uses the example of economic growth, that at the time of the Club of Rome, limits to growth, the international system was trying to work out how best to deal with poverty, inequity, environmental degradation, and they came up with the answer of more growth. Surely that's the way to solve all these problems. We can think the same about road congestion. Let's just build bigger roads. They just fill up. We could think the same about hospitals. We have more and more demand. Let's just keep building hospitals. Maybe we should start thinking about preventing some of that illness. So I don't have time to go through all of this, but I think one of the main points is to really realise that the most powerful actions we can have are up at that end of that far point away from the fulcrum. That's about changing mindsets. It's about changing the paradigm. So we could think about Aboriginal ways of thinking versus Western ways of thinking. Is the planet there for our purposes? Are we there for dominion over nature? Or actually, are we part of nature? And it is our role as a steward, as a member of an ecosystem, as opposed to the dominating force. From a healthcare perspective, we could think about, have we set up our health systems just to treat disease? Is that what health really is? Or is health a much bigger perspective? The other thing that Donella says is that actually all of those actions further down, whilst less impactful, if there's enough people doing it that can trigger action further up, that is useful. So when I was thinking about this earlier on, I was thinking about the kind of positive and negative feedback loops. If we vaccinate more people, we can use that negative feedback to reduce the amount of disease and therefore the amount of emissions from healthcare. If we reduce over-diagnosis, we then reduce over-treatment. So that's a positive feedback loop. Thinking about information flows, we've already talked about dashboards, as Paul was showing, that is showing some of our activity. I know there's work on patient surveys, for example, or staff surveys, which quite obviously reveal that people want more action. Moving on, one of the things that the Institute uses a lot is this thing called the Transition Dynamics Framework. This is some work that is built from water-sensitive cities, where Rebecca Brown, who's a previous director of MSDI, really studied how change happened to move from stormwater essentially being something we could just discard that was harmless, to understanding actually that stormwater is a really important resource, but it does need some treatment. And so she will, looked at both the old culture, policy and practice, and then moving to the new culture, policy and practice. You can define these various steps. It takes a while to get the momentum going, but then you get through an acceleration phase, and then you get into that new policy and practice. And we can think about that for health as well. And at the consortium that Maddie was mentioning on Monday, we all, asked ourselves from our own organisations, from the Australian system, where did we think we are on that point? And I think the general consensus was that perhaps we're somewhere between 2 and 3. But we do need to know where we're going. The other thing that this transition dynamics framework does is it identifies enabling factors. We've heard loads of enabling factors already, but they're really, really critical. They often get left to the end, and we kind of quickly think, oh, we need these few things that must be in place. I think they're absolutely fundamental to actually making change. And this framework allows you to look at each of those enabling frameworks and your point on the journey and work out where you are and what the next steps should be. And I've just, shout out for the Monash's Health and Climate Initiative. This touches on many, many of those enabling platforms, enabling factors, and particularly champions, platforms for connecting, and the importance of knowledge. However, one thing that we have kind of evolved from the S-shaped curve is to the X-shaped curve. And that's a recognition that it's not just about adding stuff all the time, and it's also about taking stuff away. From a big macro perspective, that might be our use of fossil fuels or, gas-driven cars. From a healthcare perspective, again, we could look at some of the harmful or low-value care that we do. What is it in our day-to-day practice, in our service, in our institutions that we could stop doing? So I'm going to now move on to the more micro level, which is around behaviour change. This little picture is from Monash Sustainable Development Institute. We're an institute for sustainable development, yet we still can't get people to switch the lights off. And one of the things that is most noticeable about this picture is that whoever was trying to get people to switch the lights off started with one notice, and then a second notice, and then a myth busting, and then a big notice, and we still don't turn the lights off. And I think the bottom line for this is that you can tell people what they want to do, what you want them to do, but that's unlikely to actually change behaviour. The other thing to be aware of when you're changing behaviour is that not everybody thinks like you do. And so don't make assumptions about what it is that's going to make the change that you want in the actions of people throughout the system. There's many, many different models of behaviour change. These are the kind of 8 factors that MSDI's behaviour works have identified from the research as the ones that are most powerful in driving our behaviour. And on the left-hand side, they're the ones that are sort of the fast-thinking, automatic type behaviours, or things that drive our behaviour. And on the other side, you have the things that are a little bit more deliberate. And you can intervene in all of these areas. Again, many frameworks for how to address behaviours. This is one of the simplest. It's called the EAST framework. It's from the UK. And it's pretty common sense, but you actually need to sit down and think through how does that apply on your particular situation. So you need behaviours to be easy to perform. It's helpful if they're socially acceptable, and it's the influential people who are delivering those messages. If it's attractive and fun, that will help, and urgent. And similarly, have you got the timing right? Is it relevant from a timing perspective? And that's that sort of never waste a crisis conversation that we were having earlier today. This has been distilled even further by our colleagues in Behaviour Works Australia into something that they call the method. If you're interested in exploring that more, essentially they understand the problem, then they understand the behaviour, and then they work with people on the ground to work out what the intervention should be and what the impact is. And they've just recently published a book called Inspiring Change. So the joke is always they've written the book on behaviour change. Moving on quickly. The third thing that I wanted to talk about is how we use our power. How do we communicate the change that we want to see? I often hear people say, I don't have any power in the system. It's the government that needs to change things, or it's the policymakers, or it's the chief executive. And I think it's just worth always bearing in mind that wherever we are in the system, we have personal power. Some of us also have that kind of positional professional power, but everybody has personal power. There are also a whole range of frameworks of persuasion about how, when you do communicate with people that you want to influence, think about how you're designing your message. Again, it's not just about the knowledge that you want to confer, it's also about whether you are using all 7 of those different perspectives. So some of those will be obvious to you. Reciprocity, you scratch my back, I scratch yours. Social proof, everyone else is doing this, why aren't we? Consistency, this is absolutely consistent with good, high quality care. Authority, this is what the government wants us to do. Liking, you're a nice person, I'll do it for you because I like you. I think that's why quite a lot of us on the panel. And scarcity. I don't know, Nick is in town. We've got a wonderful opportunity to listen to Nick for his knowledge. And unity, which is the most important thing actually in the centre. It's a principle that was added late, but it's that people like you are doing this behaviour, are doing this thing. It's really, really important to use that. And as healthcare professionals, we can have a huge amount of influence that way. Then the last thing I wanted to talk about is how ideas spread. This is some work from Damon Centola. And he basically says, we have this idea that communicating messages is a bit like viral messages. You tell one person, they tell 3 people, they tell 5 people, and messages diffuse that way. That works if it's a really simple behaviour. An ice bucket challenge, for example, that spread through the internet very, very quickly. But if you're looking for much more complex behaviours, you have to be a bit more sophisticated. You have to repeat those messages over and over again. You have to make sure that you're using very wide networks as well. If you only have a single point of contact between different parts of a service or between different departments, you're limiting the way that message can spread. So introducing your colleagues to other people in other bits of the departments or your divisions or your service is a much more effective way. And I think this also speaks to what we were hearing this morning about that coalescing of pockets of change. Change doesn't happen because the most influential person in the room says this must happen. Change happens because people at the periphery say and do, this is what we want to hear, and you get to a point where it's safe enough for the most influential person who's got a lot of capital to lose by getting it wrong and sticking their head above the parapet. If they already know that there is a movement behind them, it makes it a whole lot easier to make change. So, my last slide. These are just some suggestions if you're looking to make change either from a sustainability or a resilience perspective or a quality perspective. in whatever you're doing. So firstly, use the most appropriate entry points to change for your context, where you are in the system, and use your power deliberately. Find and use points for leverage. If you can get up to the top end where you're changing mindsets and values and system structures, that's great. But also recognise that there's potential for lower order change, especially if you're making that change and thinking what is the bigger change here that we want to make. Establish what good looks like. So at the top of that S-curve, that new policy, practice, culture, what is it that you actually want to see, and articulate it, and then work out how you're going to get there, who is going to help you, what are the enablers. Be deliberate again. Explore who needs to do what differently. This is speaking to the behaviour change. And think broadly about who needs to be involved in the change. We sometimes think it's only the clinicians or it's only the building people, but there's a whole network of people supporting each of that who have a role and need to be involved in those changes right from the very beginning, rather than brought in at the end and just say, hang on a minute, you missed this has an impact on us one way or the other. Understand your drivers of behaviour and make change easy. And the last thing is that whole thing about creating wide bridges, using your social networks, and really support the early adopters. We call on a lot of people to be leaders. It's really hard to be a leader sometimes. I think sometimes just being a good follower is a really important role that we can have. So I'll leave it there. Thank you.
That was absolutely awesome, Angie. Thank you. I'm going to open it up to the audience. If you do have questions, put your hand up, and there are microphones. Excellent. Got a few takers.
Thank you. So my question is based on something Nick said, but it's actually for Madeline. We've looked at healthcare workers across Victoria, and one of the things we found is about 80% of them who get any information on climate change get it from social media or from mass media. There is no sort of health-centric information channel for them. Is there any plan in your framework or in the strategy to set up any kind of central information or reliable information source for providers?
Hello? Yeah, thank you for the question. So firstly, just to say that the work that has been done in the English NHS to educate and mobilise the health workforce to lead the response to climate change is truly inspiring. I worked in the NHS for a number of years. I know that when you're onboarded as an NHS staff member, you have to do that annoying mandatory training stuff. They've got mandatory training modules on achieving a net zero and climate resilient health sector, NHS in this case. So really, there are so many opportunities for embedding this in BAU activity within health systems that we need to be tackling in the coming years. We don't have all the solutions yet, but one thing we've committed to in the strategy is to partner with South Australia Health to develop some materials that will be patient-facing and clinician-facing guidance on the health impacts of climate change, how you can recognise those, how you can communicate to, for clinicians, how you can communicate to patients about those, and how you can, support patients to basically both self-manage but also know when to seek care. So that's based on materials developed by Harvard University. They're being piloted in South Australia Health, and from 2025 we want to roll them out nationally. So that's going to be, basically some information sheets. So that will provide the underlying informational base that's needed. But then there's a dissemination challenge for getting that information out there, and then there's the challenge of uptake. They're all kind of things that we need to work out. But firstly, we need to gather the information, provide it in a centralised repository. Then we can think about dissemination and uptake.
Alistair Woodward from the sorry for jumping in. I'm Alistair Woodward from the University of Auckland. I'm interested in what Nick referred to as path dependency. This recognition that healthcare systems around the world have developed in different ways and for good reasons and different reasons. And Paul, that draws me to the question of aviation. You included in your category of sustainable travel the goal of less air travel, achieving less air travel and less business class air travel in particular. In New Zealand, we're a long way from anywhere. I did not swim to get here. And the carbon footprinting that's been done in New Zealand hospitals has identified long-distance flights as a major source of the emissions that can be linked to the hospital system. And in particular, long-distance flights by senior medical staff who've got entitlements to continuing professional development in their contracts, which essentially translates into business class travel around the world. How are you dealing with it? I mean, I say it's a sort of a path dependency issue because to some extent I think this does not apply in the NHS, where people have the opportunities to reach conferences and to get their professional development in more carbon efficient ways. Any thoughts or insights from your work in Sydney? I'd be interested.
Yeah, I agree. I agree about the what we have, the TESOL system, where specialists have those entitlements which are sacrosanct. They can't be changed. And I suppose one thing that Nick actually presented at a workshop that 3 or 4 years ago, when we were sort of just getting cracking on this stuff, and by the way, I'm totally aware that we're a little bit crash test dummies with this in terms of our carbon accounting and so on. And now that we've done it, it's like I don't think anyone's going to do it to that extent anymore, because we have these accelerator tools and it's all going to be pretty similar. But anyway, one thing that hit home, which relates to the fun comment, was just start tomorrow. Whatever it is, just start. Just do something. And it's a little bit perfect is the enemy of good. You just have to do something. And so we're just nibbling around the edges with air travel in terms of reducing business class air travel because it's less efficient and has a higher per person carbon footprint. It's one of many approaches that we have. Interestingly, I think there was a comparison of desflurane use, which is, I think 1 hour of desflurane is the same as a return trip to Melbourne from Sydney, where I am. So in other words, I've just, in the last 2 days, done the equivalent of 1 hour's desflurane. I thought you were going to ask me, how did you get here? Because because I didn't fly business class, but I did fly, and I was aware of the contradiction there, that here we are to talk about this stuff, yet we're doing this stuff that's not very carbon friendly. So I don't know the answer, is my answer. Sorry.
Hi, Georgina Kilroy from the Royal Women's Hospital. We've spoken a lot today about decarbonising our current ways of working and decarbonising our built environment and taking opportunities with new infrastructure to make sure that's green. I'm curious about the rise in digital health and the increasing emissions that's going to be required for the just exponential amount of computing power. I'm not sure if that's a red herring in the scheme of things. I'm interested in the panel's comments on that as it sort of the trade-off, I suppose, as far as the way that we currently provide care and what we see as the future of how care could be provided.
I think up until maybe like a year or two, I mean, I don't know anything about computers, right? I've got a clever phone, but I'm not particularly on top of this stuff. Up until a year or two ago, we used to, the NHS does most of its cloud computing and most of its sort of hosting with AWS and a little bit with Google. We moved over to Azure, to Microsoft like 4 or 5 years ago. And as we did that, we had a bunch of questions about what the increase in virtual wards would sort of do to, to the emissions attached to that cloud computing, et cetera, et cetera. And the answer was not much. The answer was it would increase a bit, but ultimately, if you are able to get that the electricity that powers that computing to be decarbonised, which if you're in Europe, like probably pretty acceptably doable, by 2035-ish sort of thing, then okay. I think that answer was probably correct maybe 5 years ago and maybe isn't correct now. And I think I was talking to some guys at Mount Sinai Hospital about some of the pharmacogenomics that they have there, and then some of the AI computing they started to. They've got like an entire floor of the hospital dedicated to a bunch of servers, and it's doubled the energy demand of the entire hospital, that one floor. And so I think pretty quickly, if you go to that kind of stuff, I might get worried, but I want to finish where I started. I don't know anything about computers.
My name's Fiona Sherwin. I'm from Monash Health. I work in the sustainability team, and I wanted to commend all the speakers for your fantastic presentation today, so thank you. Just a quick question from me, just drawing on what I think Angie was talking about in terms of a paradigm shift. So we know that low carbon healthcare is preventative healthcare, is avoided healthcare. And it's hard to do. Health in all policies is something that's not new. It's been around for a long time. I wanted to ask Madeleine about the operationalisation plan of the climate and health policy and its funding across Commonwealth, state and municipal governments in terms of operationalising health in all policies.
So the question was about operationalisation, financing, and health in all policies in particular. Did I miss a bit?
Particularly for sustainable healthcare, noting that it's the most sustainable healthcare you can have is preventative healthcare. So it's out of hospital healthcare.
Right, well, there's a lot there. So I'll try and pick them off one by one. So firstly, a big part of the work of in terms of implementation of the National Health and Climate Strategy, that's what my team's doing right now, and we've spent much of the last few months, well, we're getting on with implementing the actions, but we've also kind of gone large on program management techniques, developing a set of, we're treating each action as a project. We've developed project plans for the implementation of each action. We've developed risk registers. We've put the governance structures in place, developed stakeholder engagement plans, all the rest of it. So, it was we were kind of criticised when we released the strategy for not saying anything on implementation. Maybe we could have put that in. I always envisaged that was kind of step 2, and I just wanted to definitely confirm that we're very much on to step 2. Now, on financing, this is a huge challenge, and I'm not going to claim that we've cracked it. We certainly, the Department of Health has reallocated funding internally to expand the size of my team. So my team's now 50% bigger than it was when we released the strategy. And there's a huge amount that we can do as a team working with other parts of government and external stakeholders to get on with implementing the strategy. But in terms of the wider funding that is needed to, say, decarbonise the health system, that's a challenge that we still need to tackle. It's worth noting that, decarbonising the health system, most of those initiatives will be cost-saving. They will have a return on investment, they'll have a repayment period, and Nick and NHS England have done amazing work to demonstrate that. And we need to do that work in Australia here to build the business case for those investments. It's also the case, and investing in prevention is a great example of this, that the returns from those investments the monetary returns won't necessarily accrue to the people who have to make those investments. They'll accrue to a different part of the system. And so what that means is that you can't just expect every unit of the health sector to internalise to be able to make those investments so that they can internalise the benefits because they're going to internalise the benefits themselves, because they're not. They're going to accrue elsewhere. And what that means is that there needs to be a financing mechanism, there needs to be a decarbonisation fund. We don't currently have plans to that end, but I invite everyone in this room to see that as a collective challenge for the future, that we need to figure out a way to decarbonise, to finance the decarbonisation of our health system. And I suppose just, that applies at all levels. On health in all policies, this is a huge challenge for us. I would like to, I do think it's true that we've had significant success at embedding the principle of health in all policies. It's been around for a long time. I'm not aware of it having the kind of prominence in a major national policy document previously that it has in our National Health and Climate Strategy. And that was included in the National Health and Climate Strategy with the strong support of our ministers. Nonetheless, we're the Department of Health, so it's all very well for the Department of Health to say that they're committed to health in all policies. The challenge is to get everyone else to agree with that. And to a large extent, that work has lain without my team, and that's involved in us knocking on a lot of doors and saying things like, hey, have you considered, the health benefits of climate resilient housing? Maybe you should incorporate that into your housing and homelessness plan. So it's still at the level of us doing a lot of door knocking. We've had a lot of success at that level, but to really embed it at a cross-government level, that's probably the next challenge. Hopefully that answered enough of your little subparts. Yeah, thank you.
I was wondering, can I add a slightly provocative caveat that I guess prevention, particularly primary prevention and maybe outside of health, probably is beneficial, as you say, for preventing disease, but secondary prevention, particularly screening, is actually associated with a very high level of low-value care and carbon footprint, which could actually make things a lot worse.
Look, I'm really delighted to see that there is still hands up, except that I do recognise that we are at time and that people probably need to go to lunch. So I hope that some of the panel members may be able to stay around or catch them at lunch and please continue to ask questions. I want to take the opportunity to thank each and every one of you on the panel. I think incumbent on us with what we've heard today is also not to be wasteful in duplication of efforts. And so thank you to all of you who've come today to listen, to hear where we're at and to learn from the experts. And can you please join me in thanking the panel here today?